One of the ways we can do neuromuscular re-education, there's a couple ways. One is to cross the arms, and I loop my hands in, and you put your head on your forehead. Your forehead on your elbow, forearms, sorry. Head on your forehead, that's next level. My fingers are right around the CT junction, and I'm working on mobilizing that. So I'm just sliding back a little bit. And then when I get to where I feel like I had gained some motion, I'll say, can you gently try to lift your elbows up? And then that brings some extension and relax, and I can mobilize it a little bit more. So that's one way. A second way is to use a key grip hold right at the CT. So then you're on T1 roughly. I can take my other hand and put it all the way on the back of the neck. And then I can have him retract his entire neck into my hand. Good. And then I push with this hand gently. I just ride the wave. He's doing most of the work, and I just ride the wave and then relax. So I mobilize that to retrain this area, because this area has gotten lazy. The muscles are like, I don't have to do anything. We're hanging on ligaments. So those two techniques will work really well together in conjunction with the neuromuscular re-ed through taping, which is the next part. So a key component in doing a posture re-education program is patient awareness. And everywhere people are saying, bring my shoulders back, or can I have a brace that's going to hold me in that position? And unfortunately, there isn't one out there that's really giving good awareness. One of the problems with bringing the shoulders straight back is the clavicle has fascia that attaches to it. So if this is his clavicle from that perspective, this is his front, this is his back, the clavicle will rotate. But you have deep pectoral fascia and deep cervical fascia. And if you just retract the shoulders without releasing the fascia, his head will naturally go forward. And that's what you see people do. They're like this. So what he has to do is stack his shoulders. That means when his shoulders are forward like this, he's not utilizing his SC joint. This downward force of the arm, which is 7.5% of your body weight, is supposed to be absorbed by the clavicle through the SC joint. If you protract the shoulders, the SC joint isn't engaged, so your next line of action is levator, scap, and trap. We needle them, we stretch them, people theracane them. But if you are using them as coat hangers, they're also secondary respiratory muscles, so you'll breathe through them. So you're doing this awesome thoracic work, getting everything done, but the patient still is taking 15% of his body weight, putting it forward and breathing through them. What a way to reinforce a neuromuscular pattern. So you can manipulate. Doesn't really matter unless you get them to make a change. So what they need to do is a couple things. One, they bring their shoulders up, back, so the SC joint is aligned, and then down. That engages the SC joint. So when I push down on you, you feel that, right? Feels solid. Now bring your shoulders forward. Feels different, right? This puts the force through here, gets those trigger points going. This engages this joint, makes you solid. So that's easy to do. That's a lot easier than actually trying to think of your shoulders going back all day. Part one. Once you're in this position, I need you to take a breath out. And then when you breathe in through here. Yeah. So, and we'll work on that because sometimes the breathing in comes all the way through the shoulders. And you can tell that when you have patients. It's like, can you take a breath in? And they go like this. I say breathe out first because sometimes when people are in a forward head posture, their diaphragm's contracted already a little bit. So if they initiate with the breath in, they won't have enough breath. So if we do a breath out, the dome of the diaphragm lifts better, and then you have a better pattern to get that lateral costal expansion. Efficient breathing means you're not blowing off too much CO2, which one of our faculty, Lori McLaughlin, did a study on, and it shows it changes like your blood pH if you're an inefficient breather, which can cause trigger points, etc. So we're killing two birds with one stone here. So how do we get the patient to remember to do this? So what we can do is just some taping. You find the spine of the scapula roughly, and you put a strip of tape across the spine of the scapula. Yeah, I'm going to have you stack. You can have them stacked before you put the white tape on. The white tape is not, it's more of a skin protectant. I use something in my clinic called Sween Cream. It's a bit of a base. It's what they use for people who have ostomies. Coloplast makes it, so it's a skin prep. And depending on the skin type of the patient, it's not bad to use the skin prep. Then you put a couple pieces of tape on. And notice I'm not pulling too much, but I lay the tape down and I use a couple strips. Good, and you have to kind of work the tape to make sure that there's no spots that are going to roll up. Now I'm going to have you slouch. You feel the tape pull. Okay, it lets him slouch, but it tells him, dude, maybe you want to stack and breathe. Terry's reminding you. So then up, back, down. Take a breath out first. Breathe in through here. Go on your merry way till you feel the tape pull again. And it's patient choice. They can choose to do it. And most patients are like, I had no idea how much time I spent there. Typically, the course of this is the patients will wear it for about a week, as long as their skin holds up. They'll come in, they'll ask you to tape them a second time. After the second week, they're like, I got it. I don't need the tape anymore. That lasts for about 2 weeks. And then they'll say, can you tape me one more time? It's good, but I still think I'm not quite getting it. Then you tape them one more time. Then they usually have it. This awareness, when you combine it with improved range of motion and decreased pain, the patients will comply with this more than any of your other exercises they do, because they're wearing it and they're living it. So it's very effective. So this is a good way to do the taping. So I do CT junction manip, some of the Neuromuscular Re, and do some taping. If I don't have time for the CT junction manip, or the patient doesn't feel comfortable with it, I at least try to get this in on the first visit. And then I'll get to some of the manual therapy. They've just primed themselves for it, so they're aware of what I'm going to do, so they're in a better position the next time we go to do it.